Good afternoon, everyone. I'm Sam Masterson, and I serve as the President and CEO for the Myasthenia Gravis Foundation of America. Thank you so much for being here with us for day 2 of the annual national conference. I hope you enjoyed that last session on financial considerations. And I also hope you all really enjoyed the hula exercise earlier. Yesterday we had yoga, and today we had the hula exercise. And I saw in the chat was blowing up that people did enjoy themselves. I hope those breaks have really been refreshing for all of you. So this next session is called Navigating Emergency Medical Care. And I am especially proud to be able to introduce our next 2 speakers because they are 2 doctors who work very closely with MGFA and give a lot of time and lend their expertise. And so we just really appreciate the heck out of them. So it is my pleasure to introduce Dr. Amanda Guidon and Dr. Michael Hare, and I'm going to share a little bit with you guys about them first before we bring them on. Dr. Amanda Guidon is a neuromuscular neurologist at the Massachusetts General Hospital and an assistant professor of neurology at Harvard Medical School. Her clinical practice is dedicated to patients with neuromuscular diseases and particularly immune-mediated disorders such as myasthenia gravis. She is the director of the MGH Myasthenia Gravis Clinic, which is an MGFA designated MG Partners in Care Center. Dr. Michael Hare is a neurologist associate professor at the University of Vermont Medical Center and an associate professor at the Larner College of Medicine at UVM in Burlington. As a neuromuscular neurologist, his clinical research and educational interests are in the evaluation and management of adult and pediatric patients with neuromuscular disorders, particularly myasthenia gravis. Both Dr. Guidon and Dr. Hare serve on the MGFA Medical and Scientific Advisory Board, and they are the co-leaders of the MGFA Education Work Group. It is my pleasure to welcome Dr. Guidon and Dr. Hare. Welcome.
Thank
Great.
you.
Thank you. It's a pleasure to be here today, and thank you so much, Sam, for the wonderful introduction. We're honored to give this talk today on emergency care in myasthenia, and I'll turn it over to Dr. Hare, who's going to give the beginning of the talk, and then I will come back in. Mike?
Thank you so much for inviting us to speak at the meeting today. I apologize for looking rather casual. I'm working at the hospital today. So we're going to talk, this is our disclosures, but we're going to talk about emergency care for patients with myasthenia today. I always want to start with sort of thinking about how we classify myasthenia, but to sort of couch the discussion. And then we're going to talk a little bit about why patients present to the emergency room and what might happen after you get there, what the prognosis is. And then Dr. Guidon's put together a really awesome section on COVID-19 and how that impacts things now, and also how to avoid emergencies. So just to think about, when we think about myasthenia, we try and think about sort of the way that this condition behaves, and there are certain ways that we classify it. And true to any condition in the nervous system, myasthenia is no different in that it has a selective vulnerability where certain muscles are more affected than others by this condition. As you all well know, it tends to affect the eyes and eyelids, hips and shoulders, the neck. But the things that bring a patient into emergency care is when it starts to affect the breathing muscles and muscles of chewing and swallowing. One of the other ways that it's very important to think about myasthenia is with the type of antibodies that any particular patient may have circulating, because it changes the different medications that may be effective or less effective for any particular patient. So we always recommend that if you don't know your antibody associated with myasthenia, that you talk to your doctor about it so that you do, because it's important to be able to share that if you ever do come into emergency care. Okay, and then I always put this slide up whenever I'm talking to a group about emergency care for myasthenia, because it could be a very scary time as a patient to have to come into the emergency room with something happening acutely. And I think it's really important to know that over time, the likelihood that patients will die related to myasthenia has become lower and lower and lower every year since about 1950, 1960. And now that number is probably at 5% or less, despite the fact that there are more and more patients with myasthenia at any given time. So I like to make sure that everybody knows that even if you present with a serious presentation of myasthenia, the likelihood of a good outcome is very, very high. So why might a patient with myasthenia come in to the emergency room? So there's sort of three big categories that might have any particular person encounter emergency medical care. So the first is if you have known myasthenia and you're coming in for something that's unrelated to the myasthenia, a urine infection, pneumonia, something else, a broken arm, broken hip. There's lots of different things that could bring you into emergency care. The second patient is one who doesn't know they have myasthenia yet, but they're coming in with symptoms of it that will lead to a diagnosis during that hospitalization. And the third is a patient who has known myasthenia, who's coming in with worsening muscle weakness from the myasthenia. So as an example, so this is a 65-year-old person who has acetylcholine receptor antibody generalized myasthenia gravis, who has involvement of chewing and swallowing muscles. We call that bulbar symptoms. And at their last clinic visit, didn't have any symptoms from myasthenia. This person takes low-dose prednisone and mycophenolate, also known as Cellcept. And they come into the emergency room because they've had 24 hours of temperature, fever, 48 hours of burning with urination, and they've been having some confusion associated with this presentation. So this would be an example of a patient who has myasthenia who's coming in with something else. In this case, this is probably a urinary tract infection. And things that could bring the patient with myasthenia who come in with something else. So you could have a severe medical illness, so you could be having a heart attack, you could be having a stroke, you could have pneumonia, you could have an infection. And with some of the medicines that a lot of patients need to take for myasthenia, they're immunosuppressant medicines. So it may cause a person to have a less typical presentation of an infection. For example, in the example case, this patient came in and they just had a very low grade temperature, and they still could be very sick, and it may just be because they're on immunosuppressive therapy that they're not able to produce a fever like they would if they weren't on those medications. And then I think that the special issues that we need to be cognizant of is that you could be having an atypical presentation of something more typical. It could be a complication of the therapies that one takes. And then it's very important with myasthenia to know that there are certain treatments that it's beneficial to avoid if you can, because they can worsen the condition. And other medical conditions can sometimes result in worsening of myasthenia. Like if you had a hip fracture that needed a surgical intervention, that's a time that could be risky for a patient. So what can you do? So if that person had come in with this urinary tract infection, it's important to be able to advocate for yourself. And you need to know your MG history. You should share that with the doctors or the nurse practitioners, whoever's seeing you in the emergency room. It's important to try and know your antibody status, know which medications you're taking for myasthenia, and know which symptoms are myasthenia and which are not. And that's a very important discussion that you can have with your treating neurologist before you have any issues that seem to come up. And always provide the ER with information for your contact information for your neurologist. And there are lots of resources that the MGFA has that you can use to advocate for yourself. So one of the most important is that there's an app that you can download onto your smartphone or other device called the MyMG app. And it's a way that you can record information about your symptoms, but it's also a nice app because it has some things that you can show to a doctor in the ER, like a list of medications that you may want to avoid. Other things you can do on the Myasthenia website, Myasthenia Gravis Foundation website, they have an area where they have brochures to learn more about myasthenia. And on that site, they have cards, emergency cards, that I think Amanda designed, that you can use. So there's these cards that you can use. They have cautionary drugs. You can write down information about yourself, your medicines, something that you could hand to somebody who's seeing you for something else, and can allow them to take better care of you as a patient who has myasthenia. So now we're going to talk a little bit about a person who knows they have myasthenia, who's coming in with worsening weakness. And this discussion would relate to the patient with undiagnosed myasthenia as well. So in this case, this is a 28-year-old woman who has anti-MuSK, muscle-specific kinase myasthenia, and a history of previous breathing muscle weakness. Sorry. That resulted in intubation once, which we would call an MG crisis, who's coming into the emergency room with new shortness of breath. This woman gets rituximab infusions periodically and is also taking prednisone, which is steroid by mouth. She had a cough and a fever for 3 days, which is now better. She got a Z-Pak, which is azithromycin, and has been feeling short of breath for several hours, has been trouble with chewing and swallowing. That's brought her into the emergency room. At the emergency room, she seems anxious. She's having some slurred speech. She's having some eyelid dysfunction. She's having some difficulty holding her head up. She doesn't want to lie flat because she feels short of breath, and she's having significant arm and leg weakness. So she seems to be somebody who's having an exacerbation of myasthenia weakness. And these things can be caused by for multiple reasons. And you can see here there's a list. So it could be an illness like this person had leading up to this. Surgery can result in a problem for certain folks. Exposure to a medicine that can worsen myasthenia. In this case, she got azithromycin, which is one of the medicines that can sometimes worsen myasthenia. Pregnancy, stress, heat, and number 9 actually is the most common, no identified trigger. So it's important to know that there is this list of medications that can worsen myasthenia. And this list is on the Myasthenia Gravis Foundation website. It's in that app. It's something that you could sort of print out and have with you. And you can see that there's a whole host of things on the list. So some medications that are used to treat high blood pressure, some common antibiotics, certain anesthetic agents that somebody could get. So it is always important if you're coming in to have a surgery that your anesthesiologist knows that you have myasthenia. And the new thing that's out there is certain treatments for cancer that are now used can actually turn on somebody's immune system to fight the cancer and can sometimes cause myasthenia to get worse. And always, if in doubt, call your neurologist. So some of the things that we look at when patients come in with shortness of breath, do they feel short of breath when they're lying on their back, which means they're going to be reliant on their diaphragm to breathe, slurring of speech, trouble swallowing secretions, trouble holding one's head up, trouble walking or sitting independently. These are signs that somebody is getting weak and can be signs of breathing, secondary signs of breathing dysfunction. And they're important reasons if you're at home to call your neurologist, or may even be an important reason to come to the emergency room. Things that we can check at the bedside, so we can have patients count as many numbers as they can count in a single breath. If you're unable to get to 20, that can be suggestive that there may be some weakness in the respiratory muscles. We can do breathing tests as well at the hospital. There's something called a forced vital capacity, where you have somebody take in as much air as they can take in and then they blow it all out. And we can measure, according to somebody's height, how much we would predict any particular patient to be able to blow out, and compare to what we think should be normal for any particular person. And we can also measure how strong any particular person is with sucking air in or blowing air out with these two measures called inspiratory pressure and expiratory pressure. One thing that I think is really important that people know as you try and empower yourself is that you know that oxygen levels in blood are not an indicator of muscle weakness. When somebody has trouble breathing because of muscle weakness, they start to retain carbon dioxide, and it's only very, very late that somebody would have a change in their oxygenation. So it's important that you know if you're feeling short of breath and your oxygenation is good and somebody's telling you that you're fine because the oxygenation is okay, sometimes you need to educate folks. And we certainly do our job trying to educate our colleagues in other subspecialties about what to look for in patients. In fact, I was just doing that this morning to our ICU fellows. So back to our patient, we thought that she was unstable. She was having trouble with her single breath count. Her forced vital capacity was less than predicted. She had previously had a history of needing respiratory support. So she would be urgently admitted to the hospital. So what would be next? So this person would come into the hospital. They might need some respiratory support, and then would start on treatment. When we think about treatment for patients, we have certain things that work quickly and certain things that work less quickly. When somebody is coming in with aggressive myasthenia weakness, they tend to get either plasma exchange, which is a treatment that pulls off antibodies, or IVIG, which is a treatment that helps to reduce the amount of circulating antibodies and allow one's muscles to heal. We tend to avoid steroids in the first few days of starting, or when somebody comes in with worsening weakness, because for the first week or so after you either increase or start steroids, it can cause myasthenia weakness to increase. And then there are some new medications that may become available for the urgent setting, but right now we tend to use those two. I'm going to skip this slide. And then a person may come in, they may need to have some breathing support with either a mask that helps blow air in, or may even need to go on a breathing tube in the ICU while we give therapy to sort of help the muscles get stronger. And then over time, over days to a week or so, somebody will transfer out of the ICU, probably to a regular floor. We'll continue to adjust medicines there. And when somebody's feeling much stronger, then they would sort of go home with adjustments in their long-term strategy for care. I think it's important to know, I was telling the fellows this morning that you just have to have patience, because it may be that a person needs to be in the hospital or in the ICU for a week or so, but most people are going to get a whole lot better with treatment with IVIG or plasma exchange within 7 to 10 days. So it can be a very scary event, but usually we'll have a good outcome. And as I started, I just want to reinforce that the prognosis for a patient coming in with an emergency for myasthenia is still very good. And I'm going to turn it over to Amanda.
Great. Thank you so much, Mike. That was a wonderful, I always enjoy hearing you speak about this topic, and that was a really good overview of the beginning portions of evaluation and management in the emergency department. I guess one question that's common from patients that, I know I answer quite a bit is, can you predict who's going to have myasthenic worsening or crisis? And I'm curious if you want to answer that question before we go on to the next part.
Potentially. I mean, it is hard to predict, right? So some things that I think we look at is the past is a good predictor of the future. If somebody's had a lot of trouble in the past with severe presentations, I think that's somebody that I'd be more concerned about. What are your thoughts?
Yeah, no, absolutely. I think, definitely the past is a predictor, and also how recently patients are diagnosed. and how recently they're presenting. If patients are presenting recently, there's a bit more unknown in terms of maximum severity in terms of their myasthenia. And certainly some symptoms are more concerning for crisis than others that you mentioned. So trouble swallowing, trouble holding up one's head, those kinds of things. But I also find it reassuring, if somebody has very stable weakness for many years that's been ocular or confined, to provide some reassurance that the risk of exacerbation or worsening to the point of needing to go to the emergency room or be intubated is very, very low. So I think putting it into perspective, can be helpful in that way. Excellent. So to build on what we've talked about, we're going to spend the next portion of the talk talking about trends and considerations during the COVID-19 crisis in terms of emergency care and other care for myasthenia. So we'll return to the same example patient situation that Dr. Hare presented, the 28-year-old patient with anti-musk myasthenia, and a history, as we just talked about, of previous crisis, who it seems as if she is having exacerbation in the setting of a non-COVID illness. And after discussion with her, we advised her to go to the emergency room for further evaluation and management and acute therapy of her myasthenia. And like many patients, she expressed hesitancy to go to the emergency department during the COVID-19 pandemic. And so her thoughts were not uncommon. We know from larger data sets and from other experiences that emergency department utilization has declined during COVID. And that's for all conditions and not just myasthenia specific. And so the CDC performed a survey of almost 5,000 patients across the country. And in that survey, approximately 40% of all adults in the United States reported delaying or avoiding medical care during the COVID pandemic. And that medical care included emergency care in 12% of the patients, and then routine care in 32%. And so what does this look like more specifically? So this study, which was recently published in the Journal of Emergency Medicine, was a retrospective database analysis of 160 emergency departments, which were mainly in the Southeast and Southwest, though did include other parts of the United States. And they looked at emergency department volumes in the beginning of the pandemic, so from March through May of 2020. And what they found was that compared to 2019, which we see in this top line here, at the beginning of the pandemic, there was a marked dip in emergency department visits altogether, and the volume significantly decreased. We can see at the end of that study period, it had not yet returned to the baseline of the prior year. And during that same period, all-cause mortality was higher and nearly doubled. And they calculated that by the number of deaths divided by the actual emergency department volume. And so you can see here that the mortality is significantly increased compared to a dropping emergency department volume. So one might say that, of course, the mortality is higher, there's COVID in the background, but in fact, the study showed that patients with circulatory, respiratory, and infectious disease illnesses also had worse outcomes, so non-COVID infectious disease. And based on the demographics of the emergency departments that were included, they included regions of the country that had not yet been affected by COVID in the same numbers as the Northeast and the Pacific Northwest at that time. The numbers were not as high in the Southeast and Southwest during that period in the spring. And so the trend that was seen in the study and others, so this is one of the largest ones and most representative, was that for all conditions, there was a drop in seeking emergency care and a subsequent increase in mortality. And so what does this look like with some more specific conditions? Well, adult surgery patients that were studied in Europe first presented to their primary care doctor instead of to the emergency department. And this resulted in an increased number of days of preoperative evaluation and more evolved pathology, increased hospital days, and increased morbidity without affecting mortality. And this is the same for pediatric patients where the volume was significantly reduced during that time. And so in contrast to the risk of the perceived risk of contracting COVID in a patient care setting, the actual current risk of contracting COVID is very low. And why is that? Well, there have been many measures that have been implemented to reduce transmission of COVID. Those are along three main pillars. The first is universal source control, so covering the nose and mouth to contain respiratory secretions. For hospital facilities and clinics, there's universal mask wearing for all patients, staff, and visitors. Patients are screened before coming to attention, and staff have to fill out attestations before entry. There are reductions in numbers of visitors to patients in the hospital to reduce the total volume of people in the hospital, and sometimes reductions in the number of patients to allow for more distancing in waiting rooms and other common spaces. There's early identification and isolation of patients with suspected disease, including separate respiratory care clinics for patients with suspected COVID. There's also the second pillar, which is the use of appropriate personal protective equipment, or PPE, when caring for patients with COVID-19, and special guidance for aerosol generating procedures. There is environmental disinfection as the third measure to reduce any transmission and lower the risk in healthcare settings. And so we see that the risk of contracting COVID in a healthcare setting is very low, and there have many steps that have been implemented to mitigate that. But even still, utilization in various areas of healthcare may not be impacted uniformly. We know that care avoidance or delay is complex and likely multifactorial. In this large study that was referenced before by the CDC that was published in the Morbidity and Mortality Weekly Reports, self-reported avoidance of care for both urgent and emergency and routine medical care was higher among unpaid caregivers for adults at increased risk of COVID. So people are foregoing care to protect their loved ones or family members or friends around them who might be at higher risk. It was lower for patients who have two or more underlying health conditions, so increased concern about contracting COVID or possibly having severe COVID. For patients who have disabilities, and for patients who are Black or Hispanic, who are adults compared to white adults, and patients who are young compared to older adults. And so from these self-reported data from earlier in the pandemic, it appears that care avoidance or delay is multifactorial and does not affect all groups equally. So how does that affect care for our patients with myasthenia? Well, even more than ever, we recommend not waiting out symptoms alone. If you're having symptoms, reporting them to your neurologist, deciding whether symptoms warrant attention and where, what level of care, and then seeking care in the emergency department if needed. Having information at hand about myasthenia is particularly useful, including the medication list that Dr. Hare referenced. Given visitor restrictions in the emergency department, So having your own patient information and knowing that there might not be the opportunity for others to report symptoms or your history on your behalf as much as usual. And then obviously the system changes and adjusts depending on the level of risk in a community. So back to our patient, she was advised to go to the emergency department. There was some initial hesitancy. Her concerns were discussed. And then she asked which emergency department she should go to. And this is a common question in myasthenia. Many patients seek their neurologic care at a great distance from where they live or where they seek the rest of their medical care. And so our general thoughts about where to pursue care are pretty much the same as in non-pandemic times, in that it depends on the patient and the individual situation. Additional COVID-related considerations, which we've talked about, are limitations on visitors, which may influence decision-making, and then disruptions at times in transportation or dependent care. And we've talked about if the presenting concern is myasthenic exacerbation, but what if the presenting concern is actually COVID-19? Typically, we recommend presenting to the local emergency department or local respiratory care clinics. An exception to that would be patients with complex or poorly controlled myasthenia. Obviously, if patients are having such urgent symptoms that they could not travel or be transported, or if they're having myasthenic exacerbation, it may be beneficial to present or transfer to a tertiary care center. If patients have a history of respiratory failure or severe swallowing or limb weakness, that might be another reason to seek a higher level of care or a tertiary care center, because initial data suggests that COVID outcome may be associated with either current or prior MG disease severity. Obviously, with volume being an issue in many hospitals, bed availability may be an issue depending on where patients are brought to the emergency room or admitted. This is a map of the United States that was published outlining where the acute and critical care hospitals are that are capable of caring for patients with severe COVID who have respiratory disease. And the areas in this tan color are areas where there is not a facility, and the areas in white or blue are areas where there is at least one facility. And you can see that the distribution of facilities is also very clustered throughout the country and uneven. And so where you present is going to depend a lot on where you live. If you do contract COVID and whether or not you are admitted or not, there is collaboration between medical teams. COVID management is typically the standard of care, and then trying to determine whether there is additional COVID-19 exacerbation. The medications that are used to treat COVID are not typically associated with myasthenic worsening. One exception to that would be the pulse steroids that can be given for severe pulmonary COVID, and that needs to be discussed with the treating team, though typically the benefit would outweigh the small risk of worsening of myasthenia, though dependent on the patient. And then there would be a discussion of myasthenia management. Does there need to be an addition of any acute therapy or changes in baseline therapy? And so last, we'll talk about avoiding emergencies in myasthenia. And sometimes emergencies cannot be avoided. No matter what is done, in terms of treatment, the myasthenia is severe and it worsens and it requires emergency care. But there's some steps that everyone can take to try to avoid getting into an emergency situation, which are particularly relevant during COVID. The first is avoiding mismedications. We saw in Dr. Harris' presentation that mismedications or reductions in medication are a common cause of myasthenic exacerbation. And this includes just trying not to being organized and trying not to forget to take medicines, but also sometimes medication refills get delayed because of prior authorizations or potential delay in the mail. So having extra medication in the event that occurs to prevent interruption. Referencing the medication to avoid or use with caution list, and then referring other providers to it, either in paper form or electronic form, and then really prioritizing routine follow-up, either in person or telemedicine. If worsening is occurring, just being in touch as we would usually with your neurologist, but particularly if symptoms are difficulty with swallowing, slurred speech, neck weakness, or shortness of breath. And so conclusions, understanding of myasthenia subtypes and history can help direct treatment. Acute management of patients with myasthenia really can be demystified through a really systematic approach that Dr. Hare outlined, and timely implementation of appropriate acute therapies. Understanding factors associated with participation in routine medical care, and also why people are possibly avoiding seeking care during the COVID-19 pandemic is really needed in myasthenia, where it hasn't been studied specifically. Encouraging patients with myasthenia to seek safe, timely, routine, urgent, and emergency care with yourself and your communities. And then continuation of routine care is an important factor in prevention of myasthenic emergencies. So thank you very much. And with that, we will take some questions. And
so
go ahead, Mike.
Few, I'll ask you a couple that came up in the chat as you were giving your excellent talk. One question that came up is if somebody has COVID-19 and they come in with worsening myasthenia, are there certain treatments that may be better than others to treat their myasthenia?
Right. That's a complicated question. It really depends on the myasthenia and depends on what symptoms are presenting. Typically, if there's myasthenic worsening, we'll use an acute rescue therapy like IVIG or plasmapheresis. COVID can be associated with some, hypercoagulable disorders, or meaning that the blood clots abnormally, and so that can influence the decision of whether to use one treatment or another. But in most patients who are not experiencing those, rare complications of COVID, either one of those therapies, could be used in the short term, and then we would adjust the baseline immunosuppressive therapies. So really, we haven't really changed our standard treatment of myasthenia with COVID, with the exception of, potentially not using B-cell depleting therapies like rituximab, in the acute setting or in this time. But otherwise, our treatment strategy has been pretty much the same. What's your approach been, Mike?
I agree. I have nothing to add. That's why I asked you the tough one.
Okay. All right. I'll ask you another one now. So, one question that is very common is about the tempo of myasthenic exacerbation and crisis. And so, a very common worry is that it will come on suddenly, like a heart attack or a stroke. And, wondering if you want to comment on that.
Yeah, so I think Dr. Guidon hits a very important question that I think both of us get asked all the time by our patients and at meetings like this one. I guess the answer that I usually give is that it doesn't usually come on suddenly like a stroke or a heart attack, where you could be feeling fine 1 minute and then feeling awful the next. It's not that sort of a presentation. If you did develop something that came on so suddenly, you should probably be seeking care because there may be something else more serious going on or something else serious going on. But with myasthenia, often the weakness will come on over hours to days, and people will feel that they're sort of getting worse and worse. And that gets at the idea of trying to prevent needing to come into the emergency room for emergency room care. So often, if Dr. Guidon or I will get a call from one of our patients who feels like they're doing worse, or they're starting to have more trouble with swallowing or chewing or breathing function, we'll try and adjust their medicines at home, or if we think they might need some kind of escalation of myasthenia therapy, like an infusion therapy of IVIG or something, we may try and do that for somebody at an outpatient setting to try and keep them from needing to come in to the hospital. Try and get on top of it before things get bad. I think that's an important thing, to always sort of stay in touch with your neurologist if something seems to be getting worse. It's always important to get in touch with us.
Absolutely. So I'm looking at the chat, and there are some great questions coming in. So one question is about a concern for avoiding seeking care because of concern for not having someone to speak on the patient's behalf. Not to be an advocate, or not to, be able to share aspects of medical history and treatment. And I think that's a really common concern. And during this time where visitors are limited, that is a concern. I would say that hospital policies and clinic policies are very different. So it's really important to check with your individual, clinic and hospital about what the policies are with visitors. I wouldn't delay care or avoid, care, because of that, with different communication tools or even speakerphone. A lot of times we're able to bring in family members through the visit and to provide some history. And, so we routinely now, ask about, is there anyone else who we should bring in those situations where patients are presenting alone. Those are my thoughts about that question. Any other thoughts, Mike?
No, I mean, I do. I feel like it's very hospital dependent. And in some cases, if somebody really is having trouble speaking for themselves, I know there are some hospitals that will allow one family member to come in. But yeah, we've tried all of those same strategies, video phones or iPads or things like that, to try and bring other people into the visit if needed.
And it's just important to mention also, because, this will be recorded and enduring material, that this is a snapshot view at one period of time, and that this, might change as the pandemic goes on, or as vaccination, becomes more prevalent in the communities in terms of visitation. So, really all the more reason to check with local policies. I think we have a couple. Yeah, I think we have one more question.
Yeah, so let me ask you this one. So we got actually two questions that asked about being vaccinated. So how careful should fully vaccinated patients with myasthenia be with protecting themselves from getting COVID, and how efficacious do we think the vaccines are for patients taking immunosuppressive medicines? Timely and important question.
A very important question. So I don't know if Dr. Howard addressed this question in his earlier talk, but the bottom line is that we think that vaccines will be effective in patients with myasthenia and who are on immunosuppressive therapy. We have, data from other vaccines in similar patient groups that show good efficacy. And so we definitely encourage, patients to talk to their physicians and be, use it as a tool as part of what they use to protect themselves against COVID. But it's not the only thing. So we know, just in general, it doesn't replace the public health measures. And we've, seen from the CDC and other, guidance that they are reiterating the public health measures in addition to vaccination. And so what I, because we don't have data about this particular vaccine in patients who are immunocompromised to date, I just encourage those public health measures even more until we, in particular, have those data about efficacy in our patient population. And so that is kind of the state of where the data are and what we recommend. Any other thoughts, Mike?
Yeah, I agree. I'm sure many of you are thinking about this. I've certainly been asked this by a number of people over the last number of weeks. There isn't enough data. There's only one paper that I know of that was published in the Journal of the American Medical Association a few weeks ago, but they were for patients that are very different than patients with myasthenia. It was based on patients with solid organ transplants who were on 2 or 3 immunosuppressive therapies at much higher doses than patients with myasthenia take, and had only gotten 1 dose of one of the 2-dose vaccines. So it was hard to interpret. There may have been a slightly lower antibody level, but I don't think it's something that we could look at and say there's any definitive evidence that these vaccines don't work for patients who have conditions like myasthenia that take immunosuppressive therapies. I think we're going to learn over time, but I would reiterate what Dr. Guidon said and say that, vaccination is very important. We're encouraging all of our patients to get it. But it's equally important for other members of the community to get it to protect you. And in the meantime, while the numbers of people getting vaccinated are going up, we should all be wearing these when we're out in public.
Exactly. Well, I think we're at time, and that's a good place to end. And so we'll turn the session back over to you, Dova. Thank you so much. Thanks.
Thank you.
Thank you, Dr. Guidon and Dr. Hare. We appreciate your time and your great talk. Thank you so much. And I want to thank everyone for joining the MGFA National Conference today. We want to give special thanks to all of our speakers and to our sponsors, Alexion, Argenx, Immunovant, Janssen Pharmaceutical Companies of Johnson & Johnson, UCB, Catalyst, CSI Pharmacy, and Solio Health. We hope you enjoyed today's conference, and we hope that you'll join us tomorrow. See you then. Bye-bye.